영광으로 박수 한번만 보지. 아니? 오케이.
Okay.
Deliver very
Perfect. Good evening, everybody. And on behalf of Merck, it gives me a great pleasure to welcome you all for this meeting called as Guide, Genuine Insight and Data Exchange. The topic for today's discussion, that is it time to look favorably at first-line immunotherapy containing combination in all IMDC groups. Can you go to the next slide, please? So let me introduce to you to the Merck Innovative Oncology portfolio. We have three pillar brands: Erbitux, Bavencio, Tepmetko. Next, please. And today's discussion will be on Bavencio. Bavencio approved in three indication: metastatic urothelial cancer, advanced renal cell carcinoma, and metastatic Merkel cell carcinoma. Next, please. And today our focus will be on advanced renal cell carcinoma. Now, talking about today's agenda. So, today's agenda, we'll be having first context setting by none other than Dr. Suresh Advani sir. Then we will have global expert talk, which is Dr. Ricky Fraser's talk, and which is followed by the Indian real world data from Dr. M.V. Chandrakant. And later, we will have a panel discussion, which is moderated by Dr. Manish Singhal. Next slide, please. And for today's meeting, we are very, very privileged to have Dr. Suresh Advani, sir. Sir is Director of Medical Oncology at Jaslok and Research, Jaslok Hospital and Research Center, Mumbai. Sir, don't need, sir has, he's a stalwart in oncology with more than 50 years of experience in oncology, treated more than 2 million patients. Sir has strong interest to develop developmental therapeutics with clinical research programs. Sir is involved in 500 plus national and international publications. Sir also received Padma Shri as well as Padma Bhushan by Government of India. And sir also is recipient of Lifetime Achievement in Oncology by Harvard Medical International. Next slide, please. With this, Advani sir, I hand it over to you for your context setting.
Yeah, thank you. First of all, I would like to thank Merck for giving us this opportunity to get together virtually to discuss on an important topic like advanced renal cell carcinoma. As all of us know, that renal cell carcinoma is a natural progression. The disease starts as a stage 1 or a localized disease and becomes metastatic. And one could see that majority of the patient at presentation have the localized disease, and the localized disease has an excellent 5-year survival and beyond that. Of course, the metastatic disease has got the really very poor survival in cell. So I think it's a advanced renal cell carcinoma, which is a big problem. Luckily, about 20 years ago, we had no treatment for advanced metastatic renal cell carcinoma. I remember we used to tell the patients that, look, we have no treatment for you. You better go home because you have metastatic disease. Chemotherapy does not work. And over a period of time, there's been tremendous improvement in the treatment aspect, that today we have so many options. We have option about the target therapy, TKI. We have option about immunotherapy. And immunotherapy also, we have the options that like PDL1 inhibitors or PD1 inhibitors, and also the CTLA4 inhibitors. So we have a lot of options. Of course, there are large number of the targets which have been identified. All these are the targets of the life cycle of the cell. And it's a natural way the various stimulus is controlled, controlling the proliferation of the nucleus or DNA, cell survival, and angiogenesis. So all these factors are important, and there are many products which are acting on all these areas. So today we are going to discuss all the different types of the treatment, whether it's immunotherapy alone or double immunotherapy, IO plus IO, or it's immunotherapy with the TKI inhibitors. And again, in immunotherapy, different immunotherapies are there. Similarly, we have a different TKI. Originally, we had only the sunitinib, and now there's a plethora of the various tyrosine kinase inhibitors. To have all this information, scientific information, we have today among us expert Dr. Ricky Fraser. He is a consultant medical oncologist specializing in melanoma, specializing in renal cell carcinoma and immunotherapy. And one could see that he has a clinical lead of the various acute oncology assessment, the immunotherapy and toxicity service. He's also the deputy CEO of Immuno-Oncology Clinical Network. So I think in last 10 years, immuno-oncology has become the branch of cancer treatment, and it has shown a tremendous progression so that some of the diseases which were considered totally incurable today are looking forward to get the cure as well. So with this small introduction, I would like to request Dr. Ricky Fraser to present his views on the management of advanced renal cell carcinoma. Dr. Ricky Fraser, please. Hello.
So thank you. Yeah, so thank you so much for such a kind introduction. Just checking you can hear me nice and clearly.
Yes, sir. We do.
Brilliant. Okay, great. I'm just going to minimize that bit. And perfect. So look, it's genuinely a pleasure to be here. Thank you so much to the team for asking me to speak. Here you can see my disclosures. I think what's important is that hopefully what I'm going to do today is give you a balanced view, because I work with a number of the different companies who are in this space, and so I'm going to try and tell you what I genuinely believe, and hopefully go through the data, which many of you will be very, very familiar with, but also just pick out what I think are some of those pertinent points. So what we're going to do is I'm going to just do a brief overview of kidney cancer. I'm going to keep that brief because I know I'm speaking to an expert group. I'm going to talk briefly about Javelin 101. And again, I know you'll know that data, but I want to pull out a few of the themes that I see in that data. Then I'm going to talk about the UK ROC and what the UK Renal Oncology Collaborative is, how it started, and how I hope it can add value for all of us for that space. And then I'm going to talk you through how I approach patients in clinic. And then I think I'm going to present a case. We may or may not discuss it, or we may come back to it in the discussion part. Really keen for this to be interactive. So don't just sit there when we get to the discussion and listen bored. Let's get some, heated discussion. Let's challenge each other, because I think these are challenging patients, and ultimately we all want the same thing, which is to improve patient care. Now, we know that about 80% of our kidney cancer patients are clear cell. We know that 2 times typically the number of men to women develop kidney cancer. I think this is really important data. So this is a little bit dated now, but this is really where the UK Renal Oncology Collaborative started. And so I used to sit in meetings and see this data presented saying that about half of patients were reaching a second-line therapy. And that was excluding the patients who were doing really well. Out of the patients who were progressing, half of them were never seeing a second-line therapy. And so on the back of that discussion, myself and John McGrain, who lead the UK ROC group, used to sit in meetings and say, yeah, but that doesn't represent what I do in practice. 95% of my patients get to second line, 60 to 70% get to third line. And so that's the sort of challenge we put out there. And so it only felt right that if we were going to be talking that our patients did so well, that we got some real data to inform our decision making. And that's what we did. And I'm going to come back to some of that data as we go through. Now, your colleague beautifully articulated that our number of options has increased quite quickly. But in essence, you know, if we put interferon IL-2 aside, which, by the way, I'm very happy to talk about, you know, I very much enjoy talking about immunotherapy. But if we part that for a second, we've really got TKIs, we've got IO-IO, and we've got IO-TKI combos. But I think the favorable risk group is a real challenge, because actually I think there's genuine equipoise in the community about what is the right treatment for favorable risk. And I think we can have that discussion today for the real patient in front of you. How do we decide if they're a patient who should get IO-IO? And I'll talk about why I don't do that. Or if they should get a single agent TKI. And in my world, if I do that, I give them tivozanib, or if we should give them an IO-TKI. And what I want us to do together is explore that data and put it into some context. We know about triplets. We're not going to talk too much about triplets today. We know that Cosmic 313, looking at Ipi, Nivo, Cabo, the data wasn't that impressive. The triplet IO-TKI has gone a bit quiet. And no doubt there'll be some more data coming through with belzutifan as triplets, but we'll park that for today because that's on the horizon. So in terms of these combinations, this is, in essence, where we stand. We've got 5 trials. Now, they've all got different endpoints, and they've both all got different follow-up, and we're going to look at some of that today. But in essence, when I'm decided on patients, and once I decide I'm going to give an IO-TKI, these are the 5 options that are running through my mind. And so what I want to do today is take a minute to walk through some of the data, some of the biological rationale, and talk about how we can make those decisions, ultimately the right decision for the right patient in front of us. Now, I think most people will have seen slides like this, you know, or a variation of a slide like this. I'm going to show you a slightly different slide in a second. But often we talk about patient factors, we talk about disease factors, and we talk about the drug factors or the treatment factors. And so when we're thinking about patient factors, we're thinking about comorbidities, and in particular, autoimmune diseases. We're thinking about, you know, that patient in front of us. When we're thinking about disease factors, we're thinking about IMDC scores, biology. We're thinking about the presence of rhabdoid or sarcomatoid features, and we'll come back to that in the discussion later. And then we're thinking about treatment factors. So some patients don't want infusions, and so tablets make sense. And some patients say, actually, I don't mind how often I need to come for treatment. I ultimately am just focused on efficacy. And then I spend most of my life managing immunotherapy toxicities, and I'll give you some educational materials that are available. They're all completely free a little bit later. And so again, I think it's important for us to know that checkpoint inhibitors don't come without toxicity, and there are both some life-threatening ones and some permanent ones that we need to be aware of and be confident in managing. So this is the Javelin data. You will have seen it. I'm not going to go through it in intricate detail. I just want to pick out some of the points that I think are really interesting in the Javelin Renal 101 data. So first of all, it's got the longest follow-up of any of the IO-TKI trials. I think that's a really important point. It's a large trial. It's just under 900 patients with a 1-to-1 randomized trial looking at the combination versus sunitinib. So again, the advantage is that nearly all the trials in this space are using sunitinib as the base mark. And so again, that's useful for comparison when we're looking at incremental improvements. And importantly here, the primary endpoint looked at the PD-L1 positive, but then the secondary endpoint looked at the PFS and OS in the overall group, with other endpoints being response rate, duration, and safety. And so things that we would expect to see, nothing particularly different in that, but a long follow-up. And I think that's a real advantage because, as we know from looking at some of the other trials, some of the other IO-TKIs that went apart much wider have come back together, and we're going to see that as we go through the data. Now, again, you would have seen slides like this, but the thing I want you to take away from this is when you look at the favorable risk patients in Javelin 101, only 22% of patients were in the favorable risk group. And we know that favorable risk patients do better on average than patients in the intermediate and poor risk group. And so I want you to remember that 22% number, because when we look at Pembrolizumab later, we're going to see that the favorable risk group was about 31%. And so if you're going to uplift the 10% on the favorable risk, I'm absolutely expecting that the data is going to look better, not because the drugs are better, but simply because you've got more favorable patients, which we know have better response rates, which we know have more durable responses. And so whilst I'm not a big fan of cross-trial comparisons, although we all do that, what I think is really important is that we look at the baseline characteristics of each of the trials and use that to understand why some of the data may look different. Now, in terms of endpoints, it met its endpoint in terms of PFS. I'm going to come back to overall survival in a second because I think that's really important. And the response rate is in the ballpark that we expect to see. So 60% response rate, Checkmate 9ER was 55, Keynote 46 about 60, LEMPEM a little bit higher, but again, more favorable risk patients. So again, we need to look at the context of the data, but response rates in the same ballpark as all the other IO TKI combinations. Now, this is a graph that gets a lot of criticism amongst renal clinicians because in this data, despite the longer follow-up, the OS didn't hit statistical significance. However, I think if you look at this graph, and we'll look at some other graphs later, these separate and they don't come back together. And so whilst it didn't hit 0.05, it didn't hit statistical significance, there's interesting bits about how they spent the alpha in terms of why that might have happened. And what I want us to do is look through the context of the data and not just think, well, it didn't meet OS and therefore it clearly isn't as good. I think these curves go apart, they stay apart. And clearly, as we're going to see in a second, more patients who progressed on sunitinib went on to get IO in the second line. And so we'll come back to that shortly. And so inevitably, this is going to affect what we see. We also know that cabozantinib, lenvatinib and everolimus are better second-line treatments, in my opinion, than exitinib. So Axis trial, PFS, a few months. If you look at the cabozantinib Meteor Cabo Point trial, Cabo we're typically seeing around 30–35% response rate. So again, I would expect patients who have had sunitinib and then get Cabo to do quite well with it. And many of the patients who've got axi-nivolumab won't need to have gone on to another therapy due to that durability of IO. And I'm going to come back to the durability bit in a second. So this is some real world data. I know we're going to look at some Indian real world data a little bit later. So I work in Valindra in Cardiff, and we were part of the UK EAMS group. And actually, that's what I saw in clinical practice. So that 60% response rate is pretty much what we saw in our real world data across 127 patients. So even slightly better. PFS, slightly better. It's very rare in the real world that you see data that's better than the trial data. And so again, I find that really reassuring data. I'm not going to mention the UK ROC data yet because I've got some slides on it, but I think it's going to be really important to look at the size of UK ROC and the data that we've got in the favorable risk and how we can use that to inform treatment choices. Now, like any IO-TKI, there is some toxicity. I'm going to talk about that separately a little bit later. But again, I want you just to look at the grade 3 toxicity rate of about 15% and looking at the use of glucocorticoids, so typically prednisolone, again, sitting around 15%. And we're going to have a look at some of the other data sets a little bit later to see how that compares. when we look at toxicity, and I spend my life managing toxicity either through the assessment unit or through the immunotherapy toxicity service, most of the side effects I see day to day are driven by the TKI. So it tends to be things like diarrhea, hypertension, fatigue, hand and foot syndrome. Yes, there are IO-related adverse events. We're going to talk about them, and I'm a big advocate for improving the way we manage them. But a lot of what we see day to day are TKI-driven side effects. And the beautiful, I think, advantage of exitinib is a half-life between 2 to 6 hours, which means if I don't know what's causing the diarrhea and I stop the exitinib for a couple of days, it will be out of the therapeutic range. And if that diarrhea is TKI-driven, it will be settling. And if it's not settling, I can manage it as an IO tox. If you look at something like cabozantinib with a half-life of more than 100 hours, actually we've got a real challenge on knowing if it's IO or TKI that's driving it. And even lenvatinib has got a half rate of 28 hours. And so again, it's more difficult to pull apart if this is IO or if it's TKI. Now, I am by no means a quality of life expert. I think I can agree that this data looks like this similar, and it looks like quality of life is incrementally getting better over time. So no great surprise there. But actually, again, if we look at the small print, the patients were asked about their toxicity burden in the 2 weeks off their sunitinib. And again, anyone who uses sunitinib or tivozanib or other drugs where you get a break, we all know, be it psychological or true, patients always feel better on the break. And so I'm not entirely sure this is a fair comparison, but even so, there's no detriment to the combination compared to single agent. So I'm in Tenerife because I'm giving a talk here tomorrow. It's beautifully warm here. And so I'm looking at those 3 ice creams and I'm thinking I quite fancy all 3 of them, but that's not an option. What we've got to do is decide which treatment we're going to use up front. And so in essence, we've got active surveillance. We can talk about that later. Increasingly, I use less active surveillance. Now I've got good treatment options available. We've got TKI on its own. And again, if I'm going to do that, I typically use tivozanib. I think it's got the best data in terms of safety. And if I'm using single agent TKI, I'm not aiming for durability. I'm aiming purely for quality of life. IO, I tend not to use in the favorable risk, and that's primarily driven by response rate. And I'll come back to that in a second. And if I decide to use IO TKI, we need to decide between these 4 different combinations. So if you're only going to take 2 pictures of any of the slides today, this is probably one that would be worth taking a picture of, and then the one with the educational resources later. And so this is what I call a unicorn Wendy house. And I'm not sure how well Wendy house is going to travel as a concept. But when I was a kid, I had a little Wendy house that I used to play in, and I have a love of unicorns. And so I made this pretty diagram to help me work out how to use the right treatment for the right patient. And so if I just kind of walk through it, we know that IMDC score is important. We know that favorable risk have an IMDC of 0. And so we need to use IMDC as a marker of biology because we know that favorable risk tend to have a more angiogenic signature. I'm a big advocate for get used to using a TKI and know how to titrate it up and down. And again, one of the reasons I really like exitinib is you can start at 5 milligrams BD. After a couple of weeks, you can try and escalate to 7, then a couple of weeks later to 10. But if I need to, I've got patients down on 3 milligrams or 2 milligrams or even 1 milligram. And so I really like the fact that I can move between those different levels and use the really short half-life to be able to guide toxicity management. There's no point in having a combination if loads of patients need to stop one of the drugs because it's too potent. And so again, lenvatinib and pembrolizumab, we know from HOPE 205 that the standard dose is 18 milligrams. And we know from looking at the HOPE 218 data that reducing the dose of lenvatinib wasn't equivalent. So we know that dose is important with lenvatinib. And in the CLEAR trial, they chose 20 milligrams of lenvatinib. a dose I've never used in renal cancer. And so to me, it's no great surprise that they've got the best response rate in PFS, because I think we're overdosing the majority of patients. And we see that with a dose reduction rate of about 70%. I think it's massively important, that's why it's in the middle, to think about patient choice. And I'm going to talk about how we should integrate that in a second. We've got guidelines out there. We're going to talk about PFS and OS as we go. I like the dosing of exitinib for the reasons I've told you, and we also need to think about quality of life. So I use this unicorn Wendy house when I'm trying to work out how best to approach the individual patient in front of me. And it gives me a little bit more granularity than just thinking patient factors, disease factors, tumor factors. So when I'm thinking about the TKI versus IO-TKI, I'm really thinking about, am I aiming just to maintain a good quality of life, or am I aiming to get my best treatment in first? And so many people used to sit in meetings, like me, I was one of those people who used to say, well, it doesn't matter what you do because 90% of my favorable risk will go on and get second line anyway, and I'll just give them the nivolumab, and so it doesn't really matter because they all get IO in the end. And so I used to say things like this when I used to stand up in meetings. When I speak to my patients, though, they will say to me, Rick, actually, what I really want to see is I want to see rapid control of my disease. I want to try and avoid needing to be admitted lots of times to hospital because my cancer's getting worse. And I think really importantly, they say to me, I want a chance at durability. I accept that you may not be able to cure me, but what I'm aiming for is a durable outcome. But frankly, who cares what I think? Because that's what I see in my UK practice. What is much more important than what I think is what this data set from 2023 at ASCO was presented. I thought this data was absolutely brilliant, showing again in real world data, when we ask patients what's important to them, the things that are important to them are to control their disease, durability, rapid reduction of tumors. And so forgetting what we want as clinicians, because ultimately the priority for all of us is our patients, what our patients are telling us, not just my patients, but patients more globally, are telling us that they want to control their disease, they want durability, and they want rapid reduction of the tumors. And so for me, what they're saying is what they really want is an IO-TKI, which I think hits those endpoints. So this is how I approach it in real life. I see a favorable risk patient. As I said, I'm parking our IO for now. We can come back to it later. I see it as either TKI or IO-TKI. And if I go down the TKI, I typically give tivozanib, but again, any TKI is fair game, I think. And then if I give IO-TKI, I've got these 4 combinations to choose from. And so what I want to do is be guided by the data, not guided by what my gut feeling is. I try and use data to guide what I'm doing. And so this is UK ROC, and I just want to very quickly talk about what UK ROC. So UK ROC was an idea that myself and John McGrain came up with some other colleagues a few years ago after sitting at those meetings, and we said, look, if we're going to sit at these meetings and criticize the data, we should at least get off our bottoms and create and collect some data in our sites. And in fact, if we're going to collect it, why don't we do this on a national UK level? And so we managed to include 17 sites from across the UK, looking at what was real world practice across the UK for patients in the front line with metastatic kidney cancer. We looked at subsequent lines as well. We'll come back to that, but we're primarily interested in 2 things. One, the drop-off rate between first and second treatment. And that was the paper that I was first author on. And then what are we doing in the favorable risk patient, the paper that John was first author and I was second author. And I'm going to walk through some of that data now. Interestingly, if we look at the patients, it looks like real life. So double the number of patients were male to female. 1,319 patients were included in this data set. So this is a large data set. And actually, we've got more favorable patients in this data set than we had in Javelin 101 or indeed any of the other trials. And so again, really important that I think, despite it being retrospective, I think this is a good data set in terms of number. And interestingly, 22% of patients, exactly the same as Javelin 101, have got favourable risk disease. 80% of clear cell. We can talk about management of non-clear cell later. Again, I think that's an interesting discussion. But what I want to bring home is that this is fairly representative, I think, of the patients we see. About 8% getting sarcomatoid changes. And again, happy for us to have that discussion a little bit later. Now, this is really, really important. K5, who's a really good friend of mine in Cambridge, presented some data in 2016 showing that about half of patients were getting to second line. John and I said, we think that about 90% of patients are getting to second line, and we were wrong. So in reality, just over half, almost 2/3, but not quite, are getting to second line. 40% of patients, even when we don't include the patients who are still doing really well on treatment, of those patients that progress, 40% of them are never getting a second line therapy, and only a quarter of patients are getting to a third line therapy. And so what that tells me is this idea of saving your best treatments for later simply doesn't stack up in the UK real world. And so this has clinically changed my practice to try and get a combination in frontline. And for the reasons I've said earlier, for me, that would be an IOTKI. Now, I think this data is really important. I think that the picture's really pretty, but I don't want to spend too long on that. What I want to look at is this. Because the other thing that John and I said is, well, yeah, okay, so not everyone gets to a second line, but that's probably because all the poorest patients are dying really quickly. I still think about 80 or 90% of my favourable risk patients are getting to second line. And again, that's simply not true. About a third of our favourable patients in the real world practice, 1,300 patients, are not getting to a second line therapy. And so again, the idea that we can save our favorable risk patients and use them and use our IO or better treatments in the second line, again, just simply doesn't stack up. And again, if anyone wants to read those papers, they're free, easily accessible. One of them's published in ESMO Real World Data. And again, the other one's in Cancer Medicine. So again, freely accessible. Now, this I think is even more important. My personal view is I don't think any renal cell cancer patient should die without having IO as part of their treatment. It doesn't give durability in everybody, but if this was my relative tomorrow, I would not let them die without having immunotherapy. And if you don't give immunotherapy first, 50% of patients in our data set of 1,319 never got IO if they didn't get it frontline. And I think that is a disservice to our renal cancer patients if we don't at least give them the chance of the durability that IO can bring. Again, who cares what I think, but ASCO is usually quite useful. And so ASCO recommends for the favourable risk that we should be using IO-TKI combos. So that's important for us to bear in mind. And then in terms of real world data, and I'm going to move on after this, but again, I want you just to take note of this. So bearing in mind, our favourable risk group was bigger than Javelin 101. When we looked at the overall survival and 95% of all the IO-TKI being used was axiavelimab, we did see an overall survival benefit in the real world with a hazard ratio of 0.42. And I think if you saw 0.42 hazard ratios in overall survival in the frontline space versus TKI, you'd snap someone's arm off for it. And so again, I absolutely appreciate this as retrospective data. But again, I think we should at least bear it in mind that in the real world, there does seem to be an improvement in overall survival, except in all the caveats of retrospective data. So again, just to finish question one, so I'm sitting down with my treatment tree and I'm saying, am I going to go with TKI or am I going to go with IO-TKI? Now, based on the drop-off rates, so 60% getting to a second line, 40% being lost, the fact that favorable risk equally drop off as well as intermediate and poor, and the fact that half, if they don't get IO frontline, don't get it at all, I now give IO-TKI to all of my frontline patients unless there's a good reason not to. And so that's been practice changing for me. But that doesn't solve question number two, which is, if you're going to go IO-TKI, which of those four combinations should we be using? So let's look at the data. When we're looking at the TKI comparator arms, two of them are using exitinib as their comparator arm. So we've got axi-pembro and we've got axi-avelumab. For the reasons I talked about earlier, I really like using exitinib. Favorable risk patients, we know, tend to be more angiogenic driven. And what we want to try and do is avoid targeting too many receptors in a relatively angiogenic driven tumor, because what we don't want is extra side effects without necessarily increasing efficacy. And so we know that cabozantinib and lenvatinib target many more targets than just exitinib, which is a pure VEGF. Equally, I don't think exitinib is a great drug beyond the front line. And so again, I'm very comfortable using Len-Eve if I want to get a good response rate second line, or even cabozantinib based on the Cabo Point data after IO-TKI. I'm less confident about using exitinib. And so for all of those reasons, I think there's a good argument to use exitinib. And we've also got the half-lives, which I think is very important when it comes to toxicity. And for me, the fact it's got a really short half-life gives us the advantage that if we have got toxicity, we can stop the drug, and within 24 hours, I'm expecting things to start improving. And that's very different to things like cabozantinib, more than 100 hours, to tivozanib, again, more again. So short half-life in this space, I think, can be really useful. But even using all I've given you so far, we've still got a dilemma, because even if we're going to use exitinib as the TKI arm, we've still got to decide between avelumab and exitinib or pembro exitinib. And so how are we going to make that decision? And so again, let's look at the data. Who cares what I think? Let's look at the data that we've got there available, both in terms of efficacy and toxicity. This isn't my data. This is the data from the trials. If we look at just those two arms, if we focus on Keynote 426 and Javelin Renal 101, well, if we're looking for survival, if we're looking for durability, if we're looking for improved overall survival outcomes, which we know patients want, the hazard ratio in Keynote 426 is 1.10. It's negative, and actually, at least looking at the data, forget what my opinion is, the data suggests that it might be negatively impacting on survival. I didn't make the data. You by all means, you can push back on the data, but that's what the data shows. And then again, if you look at the response rate in the favorable risk group using axi-pembro, it's about 68%. If you look at it in Javelin Renal 101, it's about 76%. So again, data is supporting, not my data, the data from the trials is supporting a better OS, a better hazard ratio, and a better response rate using axi-avi in the favorable risk patients rather than using axi-pembro. Not my opinion, just what the data tells us. And again, I've mentioned this earlier, that if we look at the real world data that we've got in the UK, bigger than the favorable risk group in Javelin 101, we've got a hazard ratio that looks even better. And again, we haven't got that data for axi-pembro. What we do, though, is have the trial data that tells us the hazard ratio was 0.73 versus 1.1. And in the real world, it was 0.42, and confidence interval didn't cross 1. So then you may say, well, fine, but I'm not sure I buy that there's any real difference between pembro and avelumab. Well, I think there probably is some difference. So we know that Pembro is an anti-PD-1, and so it will target both PD-L1 and PD-L2. And so we know that that blockage may stop the translocation of NK cells. So again, I've got a big interest in immunotherapy. And it's thought that the avelumab does more work in pulling in NK cells and therefore enhancing the immune system than PD-1 does. And so based on the mechanism and the efficacy data, I think it's very reasonable to use Axiavi for this group of patients. And then my final few slides, what about toxicity? Because, you know, if it's good in efficacy, what if the toxicity is much, much worse with Axiavi? Well, again, that's not what the data in the trial tells us. Forget what our own personal biases are. What does the data tell us? Well, it tells us that there were less favorable risk patients in Axiavi compared to Pembro-Axi, that the grade 3 side effect was slightly lower, even though they had worse intermediate poor risk patients. Less patients discontinued treatment, and steroid use was about half of that used in Pembro-Axi, and risk of pneumonitis was about 1/4 compared to Pembro-Axi. So on a safety front, I think it's difficult to argue anything other than that Axiavi has stronger data. And as I said, I spend most of my life managing toxicities. So the half-life of exitinib and the shorter half-life of avelumab helps in that front. Does it mean more visits for patients? Absolutely. But again, when we ask patients what matters, they're mattering less about how many times they've got a visit. They're much more interested in response rate for their favorable risk tumor and OS. And if you look at the favorable risk objectively with the data and not just what we believe, the data would support using Axiavi. So that's in essence where I get to. So I see a favorable risk patient. If they tell me they want the best possible chance of durability and response, I go down IO-TKI. And if I'm being guided by the data in the trials, I end up at Axiavi. I think it's better tolerated. The data efficacy-wise supports it. And I think biologically there's a good rationale. So to summarize, and then I'm going to hand over to my esteemed colleagues, the data is the data. You can argue it, you can disagree with it. The data's the data. And so if we're going to use the data when it suits us, I think we have to use the data to guide treatment choices, even when it doesn't come out the way we wanted it to. And so again, just remember that in the real world, a third of patients are never getting to a second line. In fact, it's closer to 40%. Half of them may never see immunotherapy if we don't give it. And in the real world, we do see an overall survival benefit for the combination of exitinib and avelumab. And so if you're going to take 2 photos from my talk today, this is probably worth you taking a photo of. So for anyone who is interested in immunotherapy more generally, there's a podcast that I do at 6 a.m. UK time every Friday morning called The Immunobuddies. There's about 120 episodes. Last week, we had John Hannon on talking about the delivery of TILs in the real world. We've had Leonard Lee talking about cancer vaccines. We've got lots of talks on toxicity, how to manage colitis, nephritis. We've got 2 podcasts on how to differentiate IO and TKI toxicities. We've had Paolo Ascierto on last week. We had Axel Hauschild on last week. We had Tom Powell's on the week before. So again, really recommend. Again, no one makes any money from these podcasts. I pay £30 a month to host them, but they're completely free and not sponsored in any way. And have been downloaded about 50,000 times in 110 countries. So again, not made, just made because we think it's best to get this knowledge out there. For anyone who's interested in immunotherapy more generally, there's something now called the IO Clinical Network. We can now take international healthcare professionals. It's completely free to join. And we run monthly webinars. We've got one on Monday next week and one on Tuesday next week. One looking at ocular toxicities of IO. The second one looking at how we manage advanced therapy toxicities like TILs, cancer vaccines, etc. And then finally, again, completely free, the first Thursday of every month, I chair with Helen, who's a consultant in Bristol, we share what's called the National IO Education Forum. About 150 healthcare professionals from the UK, Malta, India, Australia, and other countries join on Microsoft Teams. It's completely free. We have 2 talks each time. I sent an agenda out a week before. If you want to come that month, by all means you can. If you can't, there's no problem. And again, I think that will end up being 5 p.m. for some of you, and probably variations on that. So again, anyone who wants to join, either scan the QR codes or just drop me an email. And feel free to follow me on Twitter or the ImmunoBuddies, and you'll get updates on when the new podcasts come out. So again, feel free to take a picture of that slide. I'm going to stop there. I'm going to thank you for listening. We've got this case. I'm just going to present the case. We'll maybe discuss it when we get back to the discussional piece at the end. But this is, I think, a fairly standard patient. So 50s to 60s, clear cell carcinoma, more than a year ago, presents 18 months later with metastatic disease, relatively small volume lung mets, some lymph nodes, not curatively treatable with surgery or SRS. Bloods are in the normal range, good performance status, IMDC 0. And so that's exactly the sort of patient in the real world that we're going to have to work down an algorithm to decide how best to treat them. I'm going to stop there, and I'm going to hand over to my colleague who I think is going to start presenting their slides.
Thank you so much, Dr. Fraser, for that outstanding presentation. It was truly insightful. Thank you for covering the importance of individualizing treatment in advanced renal cell carcinoma as per IMDC risk group, and also sharing your real-world data, and particularly on favorable risk group, and covering the role of avelumab plus axitinib in that. And so decision tree shared by you is sort of guiding tool what to do in favorable risk group. I hope that this will really help the attending SCPs to offer IO-TKI combination with balancing safety and efficacy. And thank you very much once again, sir. With this, we move on to our next session for today. May I request the team to flash the slides, please? So the next talk, while they are just pulling up the slides, I'll just, So the next talk is on the Indian real world data on avelumab plus axitinib. And to share that, we have, Dr. M.V. Chandrakant, sir, with us. Sir is academic head and consultant medical oncologist at NH Narayana Super Specialty Hospital, Calcutta. And we are eager to hear it from you, sir, about the Indian real world data of avelumab plus axitinib, sir. Over to you, sir.
Thank you, Sachin, for that introduction. And it was a wonderful talk by Dr. Ricky. So we learned a lot of new things in the favorable metastatic RCC space. Right. So, yeah. So I will ask you to move rather than me moving.
Yeah, sir, you have to say next, like this, the team
Right,
is
right,
sharing the slides. So whenever you want to change the say next, they will do it.
Right. Okay.
Can you come back to the first slide?
Yeah, you come back to the other. I can share my end from my end
Yeah,
also.
that will be fine, sir. Yeah.
Yeah,
So
then I'll share from my end.
perfect. Yeah.
Just unshare it and then enable my sharing.
Yeah. Yeah. They have unshared it, sir. You can share it from your end.
Right. So it's visible?
It's coming up, sir. Yeah, it's there. Just put. Yeah. Perfect.
Right.
Over to you.
Yeah. So every time when I attend a Merck ISP, I learn new things. We have to we look intermediate and poor risk as different than favorable, and now there is something more we can do in the favorable space. So we were not sure whether IO or IO TKI will do better than a TKI in the favorable space, and here we go. So we have IO TKI that works really well in the favorable space with a good toxicity profile. And very importantly, from the real world, we saw almost half of them are not able to go to the subsequent line. So these are some take-home messages that Dr. Ricky could share with us. So these are really practice changing. Right. So we have been looking into the AWAY-AXI data because this was the one that came up later on, and then we went on seeing why there was no statistical significant OS benefit, and there has been a lot of statistical considerations. And if you actually look into the hazards of OS are actually equivalent. It's probably a statistical design, or the control arm is doing so well in the AVE-AXI trial, and that's why we didn't get the statistical significance. So, but in our practice, we have used AVE-AXI in all the risk patients, and we have around 20 patients across the country. And after collecting all those cases, we did come up with a poster presentation in the ISMPO conference, which just happened. So we from Narayana Hospital, me and Dr. Vivek, and then Dr. Suman Kalyan, Dr. Suresh, and Dr. Vineet. So all of them have contributed significantly for forming this real world data. And I would also thank Merck team for helping us come together and collaborate this data. Right. So this was the poster that we had, and we had Dr. Rakesh Beniti being there in the panel, also looking into this poster, and it got through an oral presentation also. Right. So just to get a hang on what this poster presentation was, this is basically a real world Indian data of 20 patients on the Javelin Renal 101 regimen of AVE-AXI in the first line management of metastatic renal cell carcinoma. So it was a multi-center retrospective non-interventional study, and we could collaborate the data from the electronic medical records which we had. And what we looked into is we looked into the risk stratification, which is very important before we start treatment in the present day. And then we looked into the response rates and progression-free survival of different risks and what is their implication. So this is what we looked into, and we also looked for the Kaplan-Meier curves, and we see what is the impact. So we had 20 patients total across, and a majority were males, and 57 was the median age, and the median follow-up time was nearly a year or so. And majority of them had lung metastasis followed by bone metastasis. There were patients who also had liver and brain mets also. So if you look into the risk stratification, this is as per the clinical trial or the other data, where you had 1/4 in the good risk, half of them in the intermediate risk, and another 1/4 in the poor risk subgroup. So we had followed up for at least a year or so. And then these are the objective responses that we got, around 55%. And this is what we saw in the IOTKI trials. And one patient did have a complete response, and the rest 10 had a partial response. And this is the progression-free survival of the overall population was around a year, 12.5 months. And as expected, favorable risk did the best, and the median had not been attained in that. Whereas intermediate and poor risk patients really did good. And we just to say that the poor risk patients with AVE-AXI regimen, the hazard ratios are very impressive. And even the poor risk patients, one of my patients was a poor risk who did exceptionally well with this AVE-AXI regimen. Right. So this is the duration of response with each patient when we treated with this particular regimen. And the subsequent treatment options were pazopanib, cabozantinib, lenvatinib, and sunitinib in the subsequent lines in these patients who progressed. So, well, this is, I mean, we saw a large real world data of AVE-AXI in the favorable risk group that did really well. And this is a very small Indian data of 20 patients showing that the efficacy and is comparable to the randomized trials. And this can be easily practiced. And after this particular favorable subset analysis has come, I think we should be using this regimen more often in our patients. And people ask, why did you use AVE-AXI when there is no overall survival benefit? So my perspective was, this is one of the best tolerated regimen among all. Like the least toxic regimen is what I can say. If a patient is frail and cannot take the Cabo regimen or the huge dose of Lenvatinib, this regimen looks really promising. Axitinib is one of the best TKI to manage the toxicities, and we have a favorable risk group now showing exceptional results. So with this, again, I would thank Merck, and I would thank all of you for your patient hearing, and looking forward for learning more during the panel discussion. Thank you.
Thank you very much, sir, for sharing the Indian experience and also your personal experience and the parameter you consider while selecting the combination in your patient. May I request the team to flash the slides, please? Perfect. So with this, we move to our next and the last part of this, that is panel discussion on IO plus TKI, close look in favorable risk group. And we are very fortunate to have Dr. Manish Singhal, sir, as a moderator for this session. Sir is a consultant medical oncologist at Indraprastha Apollo Hospital, Delhi. Manish, sir, what do you?
Hi, thank you. Thank
Yeah.
you so much. I can't start my video because I think blocked at your end.
Yeah, I will ask them. So team, can you just quickly enable Dr. Manish Singhal's video? He's not able to do it. And sir, do you? So the team will be sharing the slides from there, and I hope that's okay
Yeah,
with.
that's fine. That's fine with us.
Yeah, now it's there, sir. Over to you, sir.
Yeah. So thanks to the organizers, thanks to Dr. Ricky and Dr. Chandrakant for sharing their data sets, and of course the information on this IO and TKI. And my job is to bring home the message even louder and clearer, and what has been the practice points in India. And I think so we have a very erudite panel over here. Dr. Burman Vani, Dr. Chandrakant is already there, Dr. Sushant Mittal, Dr. Nidhi Tandon, Dr. Amol Dongre, and Dr. Rakesh Pininti. So if everybody's on board.
Yes, sir. Everybody's there.
So I think we have already heard about the data, about the various competing standards of care which we have, and including the IO-IO combination and the IO-TKI combination. So can we go to the next slide? And I think we have all heard about this data previously many times. So let me just ask Dr. Chandrakant, starting from Chandrakant. Chandrakant, what do you feel? You feel that the IO combinations appear to be quite similar to each other, or you think there are differences?
They all look similar if you look into the hazard ratios and the magnitude of benefit.
Sorry, come again. Can you be louder?
Yes, sir. They look similar for me if you look into the hazards of benefit.
So, okay. What about Dr. Burhan? Dr. Burhan, what do you think?
Sir, good evening. I also feel, as far as the data is concerned, data is there that hazard ratio appears similar. But one thing, once we have to actually see these trials, that these are not there's a cross comparison trials. So they have the problem with these trials is that we know that the inclusion criteria is a little bit different, as has been pointed out. The favorable group, they have been differently placed in these trials.
Right.
So there is a difference as well as the inclusion of the patients is concerned. But yes, as if we see the overall context, they appear to be similar.
Right. So, Sushant, what's your thought on it?
Sir, talking about the pathophysiology and the concept behind joining the IO and TKI, all of them look similar. And also, the overall survival and the response rates are also similar. Regarding the cost, also, they are all similar. So, it ultimately depends on not only on the data, but the confidence the clinician has on the molecule. I'm talking about the intermediate and the poor risk. Favorable risk definitely has a different outcome when IO.
But okay, fair enough. Okay, so we'll come to the favorable risk later. So we'll go to the next slide, and then we'll have other panelists speak about their thoughts on this same concept. So this is the OS data, and this is the OS benefit over time, which has been shown in phase 3 IoTKI studies. Dr. Nidhi, is there a concern that the tail of the curves seems to be meeting each other in all these studies, like the Keynote 426, the Checkmate 9ER, and the Clear study? Dr. Nidhi.
Yes, it is a cause of concern, especially when longer follow-up is awaited. Having said that, there is a good separation of curves in the beginning, and this shows that especially patients with high tumor burden and patients who are very symptomatic to begin with, it would be still a preferable choice.
Right. To my mind, I think the meeting of the curves means that even if you were to gain in terms of progression-free survival initially, ultimately, even if you end up getting IO drug at some point in time, it doesn't really matter whether you get it in the first line or the second line. This is my interpretation, but of course, Dr. Amol, what's your thought on it?
Hi, Dr. Manish. I'm sorry. Can you please repeat the question?
So, what's your thought on this meeting of the curves? Do you see the highlighting of the meeting of the curves?
Yeah.
So, what's your thought? Is it a concern or is it not a concern?
Well, is it a major concern? Because eventually you see the benefit doesn't last longer. So if you see in all these three trials, Checkmate, Clear, and Keynote, this meeting of curve, that means the benefit fades away.
So I'll go back to our guest speaker, Dr. Ricky. How do we interpret this meeting of the curve?
Yeah, I mean, I think the meeting of the curves is completely predictable. So if you look at the doses of the TKI used in the different combinations, if you're going to use, let's say, if we look at the Clear data, where I think there's a really nice separation early, if you're going to give 20 milligrams of lenvatinib, you're going to push up the response. That's the reality. Again, Cabo 40 milligrams is fairly punchy. And so what I think is driving the early bit, and in fact, interestingly, you don't see as much separation where you're seeing axitinib being used. And that's because most people start at 5 milligrams twice a day. And some people forget even to titrate it up to 7 milligrams or 10 milligrams. And so if you had given 15 milligrams twice a day of axitinib in the Keynote 426 or Javelin 101, you would have seen the equal separation that you see with the other combos. The difference is we've not seen them come back together in Javelin 101 in the way that we are here. And I think part of that is because you go in too hard and you break a lot of people.
Okay, fair enough. So can we go to the next slide, please?
Yeah. Manish sir, one request which is there in the chat box, that because there is some noise which is coming from your end. So whenever you ask questions, somebody is replying, requesting you to just mute. So it will be easy to hear it from others. So a sincere request to you, sir.
Yeah.
Thanks. Over to you, sir.
Right. So can we go to So this is the curve for the Vivencio axitinib, and this shows that there is continuous separation of the curves even at the end. So this is something which is, I think, quite robust in its own manner, and perhaps so what we expect is that patients who are on immunotherapy, and if the control arm doesn't get immunotherapy ever, there would be a significant number of patients who will be deemed surviving for a much longer duration of period. But I think the curves tend to catch up with each other because even the control arm is getting immunotherapy at some point in time. And those who are likely to respond to immunotherapy, they will still respond. And then that is the reason the curves start matching or start meeting again. Next slide. Next slide. So what do you consider in your IMDC favorable risk? Dr. Chandrakant, you said that they all look similar, but perhaps in the favorable risk. So what's your thought on the favorable risk?
Right, sir. So if you look into the IO or the IO TKI combinations, For the intermediate and poor risk, we are very comfortable giving this because the benefit and the side effect profile is towards the combination. Whereas in the favorable risk group, there is a feeling that probably IO or IO-TKI is more harmful than actually it works. So I was always skeptical to use a combination in a favorable risk patient. Even a Pembro-Axi or Nivo-Cabo has not shown that great benefit. So, but now after looking into the subset analysis of the real world data presented by Dr. Riki, and also the subset of Javelin Renal 101, looks like if you have a very safe regimen with least toxicity and with an impressive hazard ratio of 0.4, 0.5, even in the favorable group, I think IOTK and Avaxi has really done well in that subset.
Yeah, this is what the data shows. So, Dr. Burhan, how convincing is this data to you? Dr. Burhan.
Yes, sir. So I think the data, as has been pointed out and as has been shown by the initial speaker as well, the data is quite. It really helps us in this particular subset, the favorable group. Previously, we knew from the data from the CLEAR trial or from the keynote trial that it was not very convincing to use in the favorable risk because the hazard ratio was rather suggestive. Probably in these patients, it may be a disservice use a
So,
combination.
Burhan, I'll cut you short there. Sushant, what's your take?
So my
Sushant?
take is in this category, yes, sir. Sir, in this category of patients, we should hit them hard in the first line itself because we know that.
If it is IOTKI, if your answer is IOTKI, which IOTKI?
So Bev-Exe,
Sorry?
the data is good, the response rates are good, the hazard ratio is good in the favorable as shown by Dr. Fraser.
Okay. Bevenshu, and I thought Bev means okay, bevacizumab. Okay, Bevenshu. Okay, fair enough. Dr. Rakesh, what's your thought? IOTKI, and if IOTKI, which IOTKI?
Yeah, considering that most of these patients, if not nearly 1/3 to 2/3 of these patients may not take second line treatment, probably it's a better idea to start them with a better responsive and better outcome. IOTKI basically with less amount of side effects, axitinib definitely. And the Bevencio appears to be having a bit more edge compared to that of pembrolizumab. We did see the data regarding the favorable subgroup having a overall survival advantage there as well. It is a subset analysis, can't draw much conclusions, but at least the signal is there. I think the meeting of the curves also suggests that if the patient can take the IOTK combination with proper dosing, they can probably beat the control group. But unfortunately, most of them have a lot of dose modifications, interruptions, that probably can make a difference for the outcomes. So I would probably use a drug combination that is much more safer compared to the others. Definitely not cabozantinib in a favorable risk group in combination with nivolumab. Definitely not lenvatinib at the proposed doses. I think it makes sense to use TKI, which is a bit more not very harsher on the patients, especially the favorable risk group. We need to also consider the quality of life. Probably, definitely axitinib, and the choice between pembrolizumab and Bevencio is still there. But looking at the favorable group, having some advantage with respect to overall survival advantage, probably I'll weigh on to the Bevencio.
Very good. Very comprehensive answer. Nidhi, can you be very, very short and crisp? Your choice and which one?
Unless the patient is very old, very indolent disease, IOTKI seems like a good option in these patients. In favorable risk, the data is strongest for exitinib with evolumab combination. In other risk groups, Exe-Pembro versus Exe-Evolumab, both are fine. I'm never able to give those doses of lenvatinib.
Right. I agree. Lenvatinib is a difficult drug. Amol, your final thoughts, then I'll ask some questions to our guest speaker.
Well, yeah. So as Nidhi said, I would prefer exitinib with evolumab. So I'm in favor of IO plus TKI, not just single agent TKI in IMDC favorable risk group. And my choice would be Exe plus Pembro Exe plus evolumab.
Or evolumab. Fair enough. Dr. Ricky, what's your standard of care treatment for this favorable risk group?
Yeah, so I follow the data because it's interesting, isn't it, that we follow the data when it suits us, and then when it doesn't, we decide that, oh, maybe the data is not good enough. The data is the data, and so, you know, biologically it makes sense to use a VEGF targeted TKI. That's exitinib. If you look at the hazard ratios, the overall survival, response rate, and tolerability, you should be using axivalimab because that's what the data tells us to do.
Right. So why does it not appear in as a preferred regime in the NCCN guidelines? Why? Why not?
Yeah, so I think there's a number of reasons for that. So the PDL1 story is kind of built up based on the Contact 03 trial and the TESO Cabo and a TESO not doing so well, and so the PDL1s ended up as a comparator that people don't really know what to do with. And the reality is that in the main trial, for statistical reasons, which, you know, very happy to go into, it didn't make the overall survival benefit, and so that's why it didn't get into the recommendations. And then I think, therefore, what we need to do, because we're clever people that can look at data, is we look at the data for ourselves, and we look at the data we've got available, which is what we've done today, and make the right choice for the individual patient in front of us.
Right. Does any patient go on to wait and watch and just observation in today's world?
Yeah, I mean, I'm happy to take that question. So they're few and far between. So some patients who've got very low volume disease, who are frail and tell me that they don't want any toxicities at all, I'm happy to do a period of active surveillance. But they're now few and far between, because I think patients who've got low volume disease, we've got a real chance of durability. So few and far between. And I wonder if I'm, just as I got the mic, I wonder if I could take the liberty of answering a couple of the questions in the chat, if that's okay.
Yeah, please.
So the first question is how to utilize IO in a metastatic setting where IO is being used. So I think for me, you know, we haven't got the data here, but I think if somebody has been more than a year since finishing adjuvant therapy, I think we should re-challenge them with IO. I don't think it makes much sense to give them pembrolizumab again if you've used pembrolizumab in the adjuvant setting. And so that's the sort of patient that I would argue that we should give axivalimab, because we are actually changing mechanism of the checkpoint inhibitor. What's my choice for poor risk, symptomatic? I think they're a tricky group. I think this is, I mean, there is some data for Axiavi, but my personal preference is, if I think I've got 12 weeks to work with, I typically give them IO. And if I don't think I've got 12 weeks to work with, I'm very happy giving them either Cabo-Nivo or Lempem. That's how I would approach it. And then the final question on the sarcomoid subgroups and non-clear cell, I think that's a great question. So sarcomatoid is about 8 to 10% of patients we see. We know they've got more aggressive phenotype. Rhabdoid are not quite sarcomatoid, but they're not far away. If you can't, they should definitely get IO. There's an improvement in the overall survival and response rate in the Checkmate 214 subgroup of giving IO. So if I've got time, I would give them IO. But we presented some data at ESMO this year that actually showed comparable data between IO and IO-TKI. So I'm comfortable with IO-TKI. And then just to answer the non-clear cell question, we've now got some really nice data looking at the B61 data, so looking at a combination of Lempem. And we've got Cabo-Nivo data, we've got some axivalimab data. So the bottom line for me is non-clear cell. I would still, despite the sunny forecast data that was recently presented, I give IO-TKI to all of those patients.
Excellent. That brings in a lot of clarity in our understanding. Can we go to the next slide, please? Next slide. Next slide. Yeah. So next slide. Next slide. You're going one slide back. So yeah. So this is the data of favorable risk group, and I think this is already discussed. Next slide. Again, the overall survival data is not very clear. Next slide. In other studies, next slide. And next slide again. So this is the data. One slide back. So there was one question. Why do you think the intermediate group is not getting the benefit in the Javelin study? What can be the reason for this? Dr. Ricky.
Yeah, I mean, I don't think we know the answer to that question. I think, you know, the intermediate group is an interesting group because as you're showing beautifully here, we don't quite know what it looks like in terms of the molecular subtypes. The work that Tom Powles and others are doing, looking at the 7 different gene signatures, hasn't really borne out in bigger data sets. So I think it's a tricky group, the intermediate, because some of them are actually quite favorable, and some are actually quite poor. And so I actually find it's a very heterogeneous group. So I simply don't think we know the answer why they didn't do well in that group.
Okay, thanks. So one last bit. So I think there is a good consensus about using the Javelin data in the favorable risk group, and of course people are okay in using other regimes in the poor risk group. My last question to the panelist would be, what is their take on toxicity? So there is definitely some toxicity concerns with PD-1 versus PD-L1. So starting from Chandrakant, your toxicity concern, but be short and crisp.
Right. So if you look into the data and also my real world experience, I feel Axi is one of the best tolerated IO-TKI combination. I feel Axi is the most tolerated TKI and Away is one of the safest IO. So it's a safe combination.
Right. Burhan, your thoughts?
The same insights. I have been using it, and I have found it evolumab, especially it is a relatively inert IO of all the IO that we have available as of now.
Okay, great. Sushant.
So, sir, we all have to learn that art to manage the toxicity. We have to escalate the dose or de-escalate the dose. That all needs to be done. And definitely the performance status, the 4 factors which Dr. Fraser showed and we all are aware, needs to be considered before giving all these.
I agree. That was one of the best slides. Yes. Nidhi. Toxicities.
Real world experience, I feel evolumab is much better tolerable, though there are some studies where
Yeah, of course, every drug can cause toxicity and should. That makes you believe that the drug is working too. So I think toxicity is fine, but between the given IOs, you think avelumab is definitely less toxic.
definitely.
Amol.
Yes, I do agree with all the panelists. Avelumab has the least toxicity. With axitinib, least toxicity. I mean, I have not given to my many patients, but be it like in RCC, in urothelial, both the patients in both the scenarios I've given, and I found it least toxic amongst all other items.
Rakesh, your thoughts?
Yeah, I think in combination with immunotherapy, there will be always a confusion between TKI toxicity and immunotherapy toxicity. Given the half-life of axitinib, probably we can come to conclusion whether to add on a steroid if at all we think that there could be a toxicity relating from the immunotherapy as well. So I think it is much more practical drug when we're combining with the immunotherapy. So always axitinib in combination with avelumab, at least in the favorable group.
Okay, great. So my last question to Dr. Ricky. Dr. Ricky, in which population you will definitely not use Javelin data? Is there a population or it is the standard for all comers?
Yeah, so I think it's a good choice for all comers. I think it's for the reasons we've talked about. You know, it's a very well tolerated IO. I treat Merkel cell. I've got patients in their 90s that have been on avelumab for a number of years. So I think avelumab is a well tolerated drug. I think it's an efficacious drug. I think we see that across the different data sets. Is there a group that I don't use it as much? It would be the sarcomatoid group, because if I can give them ipi-nivo, I do. But so that would be the group. Otherwise, I'm very comfortable to use it across all of the groups.
Okay, great. So I think that settles our panel discussion. And so we have a good regime which is less toxic, better efficacy, at least in the favorable risk group. It seems to be doing definitely better than the other competitors. Whereas in the poor risk group, again, it is doing quite better, although we can't really answer the intermediate. But on the toxicity front, it seems to be a well tolerated, better tolerated regime than other regimes. So, with that conclusion in the panel discussion, I hand over the proceedings to the organizers once again. And thanks for that lively discussion.
Thank you. Thank you very much, Manish sir. I know from your busy schedule, you are not here in India, you are traveling, but still you managed to squeeze some time from the schedule and, engaging everybody into the thought-provoking questions and making them, really think before they answer. So thank you very much. You always do it better, sir. Thank you very much for being there. With this, I request now to Dr. Advani sir to give his conclusion remark. Advani sir.
Yeah, I think good evening again. I think the whole idea of how to choose the right treatment for the right patient at the right time has really become much more clearer in terms of selecting the favorable and unfavorable, in terms of selecting the combination of TKI or selecting the double IO. All these things have become now individually personalized way can be identified. So I think it's a sort of a great discussion, and I'm sure all of us have enriched in our knowledge. And I must thank all the speakers, our international speakers, as well as all our Indian colleagues who have done a great job in presenting the whole data. So once again, I thank the Merck as well as all my colleagues who have really taken so much of the effort to present the data and give us a detailed idea about how to treat the patient with advanced RCC. Thank you very much.
Thank you so much, Advani sir, to summarizing it very well. With this, we come to the conclusion of today's discussion on RCC, and I'm again thankful to Dr. Ricky Fraser sir, Dr. Advani sir, Dr. M.V. Chandrakant, Dr. Manish Singhal, Dr. Buranwani sir, Dr. Sushant Mittal sir, Dr. Amol Dogre sir, Dr. Rakesh Pinanti sir, and Dr. Nidhi ma'am for sparing their time, and it was wonderful to hear it from you. So with this, we conclude it. Have a great time. Bye-bye.